All right, let's kick it off. Welcome. We've got a pretty focused agenda today. We're going to do some program updates. Sorry, something's popping up on my screen. We're going to do some program updates, and then we're going to do a little follow-up on February's meeting on upper payment limits and multi-state collaboration in pharmacy. Those are two areas we called out for some deeper dive, and so we're going to hear from a number of folks this morning about those two areas. Then we'll have a follow-up discussion and some public comment at 10:15 a.m. and we'll wrap that up. Before we get to program updates, did you all have an opportunity to review the meeting summary, and were there any comments on the meeting summary? Hearing none, we'll leave that as is. Sarah, over to you.
Okay, Christy, can we go ahead a couple of slides?
Oh, no, I missed something terribly important. Let's go one more slide, if we could, to number 3, and we'll introduce Eli Rushbanks. He's the General Counsel and Director of Policy for $4, which is an advocacy group for patients related to hospital bills, as well as a number of medical expenses. Eli, would you introduce yourself, and we welcome you to the committee.
Thank you for that. Thank you for having me. I don't know how much there is to say about myself other than what you just did. I'm happy to be here. I'm excited.
We're super pleased to have you, and I think you'll bring a perspective on impacts of costs on members that will be helpful to the committee. Sarah, to you.
Thanks. I think for the interest of time, because we have our shorter meetings this year, if other committee members want to introduce yourself in the chat, so Eli gets a sense of who you are, why don't we do that while we go into program updates? Next slide. And one more. Thanks. All right, so a couple of updates from the program side. First off is advisory committee recruitment. So we have opened a general recruitment for advisory committee membership. We know that there's going to be some turnover among you, but we're not quite sure exactly how many of you quite yet. Everyone who was initially appointed to the advisory committee when the committee launched was appointed for an initial 2-year term, but that initial 2-year term will be up in May of 2024. So Remy is reaching out to everybody and checking in, and as part of that check-in, we are assessing whether or not committee members want to continue for another term. Once those conversations are finished, we'll know how many vacancies we have, but we have opened that recruitment. So this is a broad recruitment sort of for all positions, health system and advocates, and we'll see how many positions we're actually looking to fill in May. Applications are due Friday, April 26th. We're asking committee members to please help spread the word through your networks. If you are planning on stepping down after your initial term, one of the questions we'll be asking you individually is if you have any recommendations for other folks or others that we should reach out to as part of this recruitment. So if you're a current committee member, no need to do anything. You don't need to refill out the application, but we do need to talk to you individually. Any questions about the recruitment? Okay, next slide. We also wanted to share where we...
Who am I?
Hey, Ruth, you're off of mute, not to pick on you, can you? Thank you. Okay, so accountability update. We have convened a rulemaking advisory committee this year, and that group, the RAC, has met 3 times so far to provide input to OHA on the draft rules related to accountability for the cost growth target program. So when we say accountability, this is what happens if a payer or provider exceeds the cost growth target. So the RAC has been thinking about the process to determine whether or not cost growth was for a good reason. what that list of good reasons or acceptable reasons are, the details of that, also performance improvement plans and financial penalties. So at the third RAC meeting, the draft rules and the proposal for how financial penalties would be calculated was presented. And we are currently accepting comments and welcome input on all of that. There will be a fourth RAC meeting in April, and we are scheduling a fifth RAC meeting for May. That's not on the calendar yet, but it will happen. The draft materials, the presentation, the recordings are all available online. Committee members might remember that you last year discussed principles to guide the development of the financial penalties. While those were not final and voted on or endorsed by the committee, didn't quite reach consensus on those, we did use that to inform the proposal, and that was part of the conversation at the RAC meeting last month. So if you would like to take a look at that, draw your attention to the proposal for those penalties, and we'll keep you posted as the rules are finalized later this spring. Any questions about rulemaking? Okay, next. You're making it really easy for me this morning. So we are also continuing our educational webinar series that we've launched this year. This is a joint opportunity for Oregon Health Policy Board members and Cost Growth Target Advisory Committee members, as well as other interested folks, to learn more about background in the topics that we're covering in the committee, as well as an opportunity for more Q&A or to do a deeper dive into the data, anything like that. So we held our March educational webinar on Monday, was that just yesterday? Yesterday, focusing on patient cost sharing. That recording and slides are being posted to our website, and that's available. We are planning to focus our April webinar topic on what some of the other cost growth target states are doing around their strategy development. So this year, we're spending all year thinking about potential strategies and opportunities to address cost growth drivers. We thought it would be helpful to provide a little context about what's happening in other states. So if you have specific questions about work in other states, let us know, and we'll use that to help shape the webinar. And we'll get that calendar invite, save the date out to you all shortly. Next. And then a reminder to save the date. So we had this as a placeholder on our calendar for the beginning of the year, but the Oregon Health Policy Board has finalized or adopted their official calendar, and the Policy Board will host the 2024 Annual Cost Growth Target public hearing at their June 4th meeting. This may be a hybrid meeting with participation in Portland and virtual, and we'll be working with the board on the agenda for the public hearing and coming back to the committee as well. So this is pretty exciting. This is a more formal public hearing than we had last year, and the board will be taking a more active role in hosting that. So looking forward to this, but wanted to make sure that that June 4th date was on your calendar. We can also make sure you have the calendar invites if you need them, but please save the date for that public hearing. We really encourage the advisory committee members to attend, participate, and we will likely be reaching out to you as we continue to build that agenda to ask if there's interest or willingness to help moderate a panel, help participate, or otherwise facilitate that. Questions, comments about any of that? And I see Bill, our policy board liaison, is on. So Bill, do you have any other comments you'd like to add to that?
No, thanks. I'm very much looking forward to that meeting on June 4th. It's going to be, the purpose really here is to elevate the work that the Cost Growth Target program has been doing to identify some of the issues going forward, and really to make this a public forum where there's an opportunity for public input about what the current situation is, what needs to be done, and engage more directly with the Oregon Health Policy Board. So I think it's a great opportunity. Appreciate everyone's involvement, engagement in this effort.
Thanks, Bill. All right, that's it for our program updates. I think back to Peter and Felisa.
Yeah, Felisa, do you want to do this piece, or do you want me to talk about sort of some context for our conversation coming up?
I think that I feel like why don't we just do it a little bit jointly? Is so Peter and I were having a discussion recently about, can we just take down the slides for a minute while we do this, and then we can put the slides back up as we head into that presentation. Thank you. I think that we're having a discussion after post to the last committee meeting, which I know Peter facilitated and I watched via video. And I will say, I think one of the things that we've thought is my sort of takeaway watching it from afar and not participating was interesting. But one of the things I think is really important is we don't have to be implementation experts on any given topic. And I know that many people on this committee are implementation experts in their given areas. So it's hard to sort of step back for a minute and think, how do I not have to do this? But I think pharmacy is a really key area where we need to be idea generators, and that there are implementation experts both at the state and at the pharmacy committee who can be much more of the implementation, realistic, and policy experts about what's legal, what's possible, what's, how and where would we do that if it is possible or doable. And I think what our role as a committee, which I think is a helpful role for those other committees, is to really have a discussion about what are our ideas, what are some potential pro cons that we think about those ideas, and then how do those get vetted in other areas where it's sort of a little bit more of that expertise is housed. I think the other piece that one of my other takeaways is, I think we're limiting ourselves by sort of throwing our hands up around the federal government a little bit, which I think is easy to do. And I often find myself doing that as well, as being like, well, the federal government, we can't do that. So I think one of the things that we should think about is, how do we generate ideas, generate concepts that we can then talk with our federal delegation around implementing, how we think of it as an idea generator that we can collaborate with other states to pressure a sort of more broad federal delegation into implementing. Are there additional crossovers where we have a lot of connectivity on this call, right? We have the hospital systems, insurance systems, we have people who operate in multiple states, we have advocacy groups who have national presence, right? And so is there a way that we can be a collective idea generator where we can use that to sort of spread something in a bigger way where we actually can move some federal policy or federal government? Now, that's a very big, broad idea thinking, but I feel like this is an area where we need that big, broad sort of idea thinking and those connections to make something move and happen at that level. So I thought that was an important sort of frame as we head into these discussions and this thought process. I don't know, Peter, if you have other things to add.
No, I think it's a really important context, and I think our role is really figuring out how to achieve the cost growth. How do we help other agencies identify opportunities, or at least expose potential opportunities to them so they can implement them, so that we can start measuring the impact of that success. And that's our role, is to help the state achieve those targets, to help our organizations jointly achieve those targets.
Are there I feel like we'll take a quick minute here if there's other thoughts or things that people have ruminated on sort of about a bigger frame. We're going to have a very specific discussion later on in the agenda. There's no pressure. And so later on in the agenda, if you sort of have moments or ideas sort of about that, I think that please bring those forward, and let's kick it to Ralph and Jane to talk about upper payment limits. And back to the slides, I think.
And good morning. Just making sure folks are hearing me okay. Great. And wait for that deck to come back up.
We're going to head back to the slides. I think. Who's in charge of the slides, Sarah?
Christy, we're not seeing your screen. If you are screen sharing, it is not working.
Perfect.
There. Thank you. We
Now
now
we're
see your
seeing-
screen.
But we're not seeing the slides. That is a beautiful screensaver, though. There we go. Great job.
All
Christy.
right.
Thank you.
Thank you so much. And you can actually go to the next slide if you would. Good morning. I am Ralph Magrish. I'm Executive Director of the Oregon Prescription Drug Affordability Board. And thank you so much for the opportunity to join you again, as I did earlier this year. Also very, very pleased to introduce Jane Horvath from Horvath Health Policy, who will be co-presenting with me this morning. Jane does do work for the Oregon Drug Affordability Board in a consulting role. I will lead the first part of the presentation, and I'll introduce Jane and give you her bio when we move into her portion. So next slide, if you will, please. So what is this construct of upper payment limits? We use the term very freely. We share it all about, but what does it actually mean? So the construct actually means, and this is what we're sharing with you, is a very widely accepted working definition that is put forward by the National Academy of State Health Policy, NASHP, for which many of the state drug affordability boards work very closely with. The maximum reimbursement rate above which purchasers throughout the state may not pay for prescription drug products. Purchasers include any part of the supply chain in the state. And really important is that it creates a ceiling on what payers can pay for a drug. It does not set the price that a manufacturer can charge. And that is really, really an important thing that we need to say out loud, candidly, as often as we can. And if you would, next slide, please. When reviewing the minutes and notes, I'll just jump into a couple things. When reviewing the notes and minutes from the last meeting and anticipating some of the questions that may come up, Jane and I have really tried to incorporate what we anticipate some of those to be into our presentation, and we'll speak to them throughout, but look forward to having some question and answer time at the end. So what are PDABs looking like across the country? And there are a number of boards that do have upper payment limit authority. Oh, see my camera freaking out a little bit there. We'll hope that settles down just a sec. So Colorado itself does have authority to set upper payment limits for both government and commercial covered lives. With that said, folks, we'll share with you that last Friday, a manufacturer did file suit in U.S. District Court in Denver, arguing that the Colorado Prescription Drug Affordability Board's actions are unconstitutional because they conflict with federal laws and because they purportedly violate the rights of due process. So going to put that out there, anticipating that there was already going to be a question of what kind of legal challenges might arise from upper payment limits. Well, we have in fact seen that in the last week. So Washington State, our great neighbor to the north, still very early in their stages of development, but that board is tasked with identifying drugs similar to us that could create affordability challenges for Washingtonians. To that point, while they be noting that do not have this authority, of course, that board can set upper payment limits for up to 12 drugs each year. However, the rules that will adopt that will prohibit them from doing so until at least 90 days after the next legislative session, and that is a regular legislative session in Washington. So quite a long runway there. Minnesota, similarly, in its very early stages of development, but having the authority to set upper payment for drugs that they deem to create affordability challenges for their state healthcare system, and that upper payment limit, if those are drugs that they identify that would be subject to the Medicare maximum fair price, the board would then default to that maximum fair price as the upper payment limit. And of note, probably to a number of folks on this call as well, that measure does not require ERISA or Medicare Part D plans to be subject to any upper payment limit, and those plans may choose to exceed it. So other handful of states that have things going on, Maine, New Hampshire, New York, all have PDABs that are more advisory in nature right now, but certainly a lot of interest around the country in what we are doing, to the point of the current situation in Colorado. And broadly speaking, with all of us, I think, as I've said with all of you earlier, this is really a long game conversation, and we are still very, very early on in that. And if you would go to the next slide, please. So a little bit of the history with the upper payment limits here in Oregon. As you know, our board itself was created in 2021 without upper payment limit authority. In our first set of inaugural recommendations to the legislature in 2022, we asked for authority or permission to set upper payment limits for government payers. Legislature was not ready or prepared to do that, but instead invited us to come back this September under Senate Bill 192, and we'll speak to this in detail here, to study implementations of upper payment limits and what that could look like. So next slide, if you would, please. Thank you. This is the language of the bill and the law as it stands. But to speak to this, what does this plan really ask us to do and come back with and build? Ask us to come up with a methodology that works for upper payment limits in Oregon, what resources would be needed, how we would enforce it, how this plan would be implemented with respect to PEB and OEB and other state administered benefits, including the Oregon Health Plan. Obviously, that means both fee-for-service and benefits delivered through coordinated care organizations, and also other state licensed health plans. So if you'd be so kind, I think if you go to the next slide too, and we're going to move through this a little bit quickly, hopefully an opportunity to have some meaningful conversation and discussion as well. But to that point, in September, we're going to deliver this analysis, and this calls for us to identify potential savings from or cost of implementing this plan as it relates to the state, to health insurers, to hospitals, to pharmacies and consumers. And I'll put a little pin in another piece that I will circle back later as to another group that we will be talking to. And if you go to the next slide, please. Thank you. So where are we at with this right now? We have engaged the consulting firm of Myers and Stouffer that does support the Oregon Health Authority with the Medicaid program in actual acquisition cost reimbursement for Medicaid pharmacy reimbursement. They also work as the CMS contractor in setting the national average drug acquisition cost benchmark, which is the reimbursement benchmark used by many Medicaid programs around the country. And they have a deep bench and experience in both hospital rate setting and hospital cost report reviews, amongst many other things. So have engaged them and begun our conversations with PEB OEB folks and their actuaries to begin contemplate what an analytic model might look like, and have similarly done the same with the OHA pharmacy director and the chief actuary on contemplating what modeling of impact of an upper payment could look like on state funds. And excited to get into a little bit of detail with you when we talk about the external conversations that we will be having starting next month, that we will be working through with all the stakeholder groups and others, as mentioned. And the approach that we're going to take with that with Myers and Stouffer in those external facing conversations is that we will be putting out an initial survey instrument that's based on a SWOT analysis, or strength, weaknesses, opportunities, and threats. But we're going to take that a little bit farther and kind of call it a SWOT plus, or model, if you will. And that will be to put out the straw models of what upper payment can look like to these different groups across the state, give them opportunity to react as to kind of two partition columns of what they see as the real strengths and opportunities, and then candidly what they see as weaknesses and threats, and then other things. We're taking this format and approach for a couple reasons, and candidly the SWOT analysis format, in addition to many of us folks having leaned on it heavily through graduate school, but it will allow entities and responding folks to context and structure and deliver their message to us candidly about things that they may not like about the models that we are putting forward as weaknesses and threats, and not coming out flat out saying we don't like this or we do not support it. Because in this model, what we hope to do is to identify themes of constant support, constant concern, and be able to pivot and develop a structural model in Oregon to develop a consensus-driven approach. Behind that, it will also be a request for folks to identify what data sources and points they would put forward in support of their position, because as noted in that statutory language, it is the cost or savings opportunities to those groups. So we need to have those as rich conversations. And then as we speak here in the last bullet, if you would go to the next slide, and that is to consumer engagement. And we are very excited that we will be kicking off a series of in-person community forums here in Oregon. They will be hosted by our former state insurance commissioner, Lou Savage. If anyone knows Lou, guaranteed that he will facilitate an interesting and entertaining conversation with folks with the purpose and intent to help people understand why drug costs are so high in Oregon, and to help collect information from them to help us identify solutions. You have those dates in front of you, and then we will have several online iterations of those as well. And if you would go to the next slide, please. Thank you. So spoke to most all of this in detail earlier, but do want to call out that we believe it was important to add 340B covered entities to these discussion groups. We'll say this now and we'll say this repeatedly. We have no intention of developing an upper payment limit model in Oregon that is operationalized on the backs of Oregon's community retail pharmacies or its safety net providers. It's not going to work. It's not anything that we want to do. We recognize the importance to all Oregonians to access to their pharmacies in their local communities and the safety net providers that help them stay healthy and whole. So enough said there, I think. And if you would go to the next slide, please. So just walking through our timeline, and like most timelines, they are subject to slippage, but we are tracking yellow to green, more green than yellow in this regard, in that we will be beginning this community input throughout April and May and developing that analytic and reporting structure into June, and taking the iterative process to our board over the course of the summertime in preparation to submit to the legislature. If you would, the next slide, please. So what's to come after this deliverable? Nothing that has happened in Colorado in the last week changes the spirit and intent and goal of our mission. I'm going to read this out loud to you because we don't want to lose sight of this. And that is a goal in 2025 that a bill would be signed into law by the governor that benefits all Oregonians, and our healthcare system appropriately takes egregious profit making out of the system, preserves pharmacy access in Oregon, and promotes transparency. And if you would go to the next slide, and I look forward to introducing Jane for this piece. So just a little bit about Jane. I think many of you have heard her speak before, but so very fortunate that we have her with us, not just today, but helping to advise the Oregon Drug Affordability Board. So Jane Horvath is an experienced health policy analyst and policymaker with a deep background in Medicaid, commercial insurance markets and regulation, Medicare and prescription drug pricing and reimbursement. Jane advises state governments, foundations, private and public sector payers and providers, and consumer advocacy organizations. Jane has testified on Capitol Hill and in many state capitals on drug cost issues, including here in Oregon just this past short session in the House Healthcare Committee. Jane spent 10 years at Merck working on public and private coverage and reimbursement policies. She's worked for Medicaid directors, the United States Senate Finance Committee, and was Deputy Assistant Secretary for Legislation at the U.S. Department of Health and Human Services. Among the many things that Jane has done in her career, she helped negotiate the creation of the Medicaid drug rebate program and supported that implementation. When working for the National Medicaid Directors Association, she was involved in the creation of the Federal Vaccine for Children program as staff at the Senate Finance Committee. And as an employee of Merck, she was one of the trade association's representatives to work with federal agencies in the implementation of Part D, and again, to implement and operationalize the Affordable Care Act industry excise tax, as well as require discounts in the Medicare Part D coverage gap. Please welcome Jane Horvath, and Jane, take it away.
Thank you. I really appreciate the opportunity to be here today, so thank you again. So next slide, please. So all of you understand this perfectly. So many audiences do not, so I'm not going to go into all of the different reimbursement terms, of course. Suffice it to say that the upper payment limit in the state of Oregon, were it to be statewide, would basically be the WAC, basically, and whatever is based on WAC would then be based on the UPL for purposes of purchasing and payments and billing, all of that. So we don't need to, I'm happy to take any questions about this, but I think talking to the professors in the class about this one. So how about the next slide?
Oh, hey, Jane, just to jump in real quick, I want to caution you that we are not the professors on this topic. It's actually a mixed group there's lots of community, about 50% of the audience is community folks. And so who may not be super engaged in.
All right, well then do you want to go back?
I think it might be helpful to just do a quick.
Okay, absolutely. I appreciate that. Thank you so much. And my apologies. So basically, this is how a schemata of how the UPL would flow through the supply and then the financing chains, if you will. So, it starts with the manufacturer who has a list price or a WAC before discounts. And the manufacturer then would sell to the wholesaler at the upper payment limit, whatever that is. And presumably the whole supply chain acts like it always does, which is there's a bit of margin taken at every step of the way. So instead of selling directly at the UPL or at the list price, the manufacturer sells to the wholesaler at less than the list price or less than the UPL. And then that allows the wholesaler to take some margin on the product, but also to give discounts below list price through the rest of the supply chain so that, everybody gets some margin when they resell or dispense or administer and bill for the product. And nothing about a UPL would change any of that or should change any of it. So it uses the exact same sort of standard operating procedures that we have for the supply chain now, using the same sort of concepts of margin and how people take their profit before they resell. And then in terms of payments, insurers and PBMs are always interested in reimbursing dispensers and administrators of drugs at their actual acquisition cost, basically, or the estimated actual acquisition cost or whatever. They really want to get at that product reimbursement as well as a professional reimbursement. And the UPL would be the product reimbursement because it is the known public number. It is the acquisition cost in the supply chain. Does that make sense to folks? So it starts with the WAC.
Jane, it does. How does the industry under a UPL keep track of the various discounts and margins that each of these boxes put on so that at the end of the day, the system is not paying above UPL?
So that's a great question. So the UPL is a public number. The board posts it, and there's 6 months, typically in most states, 6 months after the UPL is decided upon to implement it so that payers understand that that is basically the product reimbursement portion of the reimbursement. And it's up to everybody along the supply chain to make sure that they do not pay more than the UPL because they're not going to get reimbursed for it if they pay more than the UPL. So there's no incentive to sort of up the game here and buy at a price higher than the UPL. Okay, so it's almost self-enforcing in a way. Okay. Any other cues on this one?
Can I ask a question? And if you're going to cover this later, please skip me, but can you talk about the interplay? Because I'm thinking about Ralph's slide that said the goal is to take some of that unjust profit out of the system, but then this slide seems like it's less about that because everyone retains margins all the way throughout. So how does that fit together?
Well, the margins in the supply chain are actually pretty small. So, and again, I'm talking about the supply chain, and the supply chain, I think language is always important, but here particularly. So the supply chain, the clearest way to think about it is that the supply chain are the entities and people that buy the drug, stock the drug, and then sell it basically to the consumer. Or, you know, the consumer buys it because they're getting injected with it, right? Or they take it home to consume it, as, you know, as a retail product. So that's the supply chain, and you know, there's not a lot of margin taking there. I don't think that that's really a significant part of our problem. There's a separate issue of 340B that I'm not going to. I'm talking generally now about how things work, and then of course we have problems that many people, if not most people, point to in terms of how the pharmaceutical benefit managers operate. But, you know, you're talking about a margin of 2%, 1%. You know, these are small margins through the supply chain, not massive profit taking. That happens sort of elsewhere, and it, you know, it is a problem. But what we're starting with here, so if there's a list price, the UPL is below the list price, right? So everything that starts, this is just sort of resetting where the UPL is resetting where the whole supply chain starts off. And the UPL travels through, the consumer knows what the UPL is, so that unlike today, people don't know what the price of the product is, like where it started out and how it got here, and what the price is here at the pharmacy counter relative to what the price was when it left the manufacturer. The consumer is aware that they shouldn't be paying any more than the UPL. And that's sort of the critical difference in this whole piece, is the consumer can know, you know, what they're, you know, if they're in their deductible, what they should be paying at the pharmacy counter for this product. Or if it based on cost sharing as, you know, 20% of the cost of the drug. So that just resets the whole term of how everything operates through the supply chain. Does that make sense? Also, Sarah, if I could just ask your assistance, I'm terrible at watching hands. I'm just not that talented. So
yeah, we had a question from Melissa, maybe not. Did you retract that?
Just a comment on the margin component, right? Because it isn't, there's expense related to stock, just what Jaden said, related to stocking, you know, handling, all of that. So there is margin in this, but I just think straight drug doesn't kind of account for the whole cost. Transportation, I mean, all the you know, all those kind of expenses related to that. So she covered it.
We good, Sarah? You think? Okay, next slide. So this is more about what a UPL might look like. And this is just me. All the boards are doing their thing and are going to do their thing. But some things I think that might be really interesting to look at, and they take in some of what the pharmaceutical industry is very upset about in terms of the marketplace. It doesn't always work for them very well anymore either, given some of the dysfunction that is out there. So, you know, manufacturers put a lot of money on the table in terms of rebates for products now, which leads to the fundamental question about why don't they just lower their price? But I'm not here to answer that one. And I don't know why they don't do that, but they don't, and they use rebates. And so you have situations where there are products where there's a lot, like the long-acting insulins that the 3 major pharmaceutical companies last year announced they were slashing their prices like 70%. Well, they did that because their rebates back to PBMs and insurers were about 70% of the list price of the product. And for a variety of reasons, Lilly was the first one. They're like, we're not doing this anymore. We're just lowering the price of the insulin starting January 1, I believe, of 2024. So a UPL could be the WAC minus the rebate. And, you know, it would make rebates unnecessary for many, many payers. Anyway, it's a way of reframing sort of how the market works. And this is one of the things that manufacturers really complain about, is that they give big rebates and the patient never sees that. The patient is always paying off of basically the market or the list price. So, and there's reasons why it works like this now, but this is something a PDAB could think about doing. And then manufacturers put a lot of money on the table in terms of patient assistance directly, like the copay assistance at the point of service, where if the drug is on a very high cost sharing tier from the health plan, the manufacturer steps in and pays some large portion of that. And you know, they do that for very specific market and revenue reasons. It's not just altruism, although I would argue it is the manufacturer's acknowledgement that there is an affordability problem here. But anyway, some portion of the copay assistance that is out there, you know, making the UPL, incorporating some of that money that manufacturers are already put on the table, for instance, in terms of lowering you know, making the upper payment limit less than the list price in a state. And there's some trick to that math and everything, but I'm not going to, I'm just talking in very broad strokes here. A board may also want to think about applying a UPL to a whole therapeutic class of products. If all the products in that therapeutic class behave the same way, they're all shadow pricing each other, and they're all giving like the long acting insulins, where all those manufacturers were giving 70–80% in rebates, and their list prices were very close together, and people were dying because they couldn't afford their insulin regardless of what insulin product they were on. You might want to apply a UPL to a whole therapeutic class if they are operating in very similar ways, and sort of sorting through the market at that level.
Question
Greg has
Yeah, thank you. I had a question that I think intersects with this bullet point, and it's that I would think that one of the challenges, or one of the potential ways that a UPL could be not avoided, but a problem to be dealt with, is that prices could be end up being increased for drugs being sold that don't have UPL to make up for the pricing limits that are imposed on certain other drugs. And I'm wondering if there are any examples or any discussions about a way to systematically define a UPL across all prescription drugs. I don't know if this is a naive question in some way, but yeah, that's my question.
Well, it's absolutely not a naive question at all. So I tend to think of it in a couple ways. One is that if you think that that's what happens, this cost shifting, basically, one product to another, then that happens now, and we should all just sort of fold up our tents and go home and quit trying to save money on prescription drugs, right? Because hospitals negotiate, everybody negotiates a discount somewhere along the line, you know, and volume-based discounts. And also, I don't think that manufacturers tend to maximize their prices. I mean, that's just what they do. That's their job, is to maximize their prices and their profits. And so on any particular product. So, you know, I think that they charge what they believe they can charge right now. And their discounts in different segments and to different purchasers reflect the extent to which they are able to maximize. And then the other thing is that in my experience anyway, manufacturers make big decisions about price increases in particular, sort of across their whole portfolio of products, right? And they do it once or twice a year. And they don't think about, we gave too much to Johns Hopkins and now we're going to raise the price over here kind of thing. So it's just it's a more strategic thing inside the company. So I just don't know necessarily that is something that would happen.
So Gil has his hand up.
Yeah, thank you. I just curious if the upper payment limit is just removing the rebate, or the current discount. What's the net result to the consumer? If it's, I mean, is there a significant reduction in cost, or is it pretty much what we have today?
Well, again, number one, this is all very contextual, right? It depends on the product, right? And the competition and all sorts of stuff about a market. And every drug is going to be different, right? I mean, the how you approach a UPL is going to depend on the drug. So, but for instance, if it were the rebate amount, then the patient would get that at the point of service, and it would be significantly different for the individual patient. Because the rebate pass-through is not a very common practice in the insurance industry, in the PBM industry. Now, the net to the insurer may be the same, right? Because they're getting billed now much, much less instead of getting the rebate on the back end. But again, I'm just throwing stuff out. All of these things are, really have to be thought through very carefully depending on the drug product that a board is looking at. These are just broad concepts of things that are, I think, possible. So, and then another one is to make the Medicare maximum fair price the statewide UPL, sort of just piggyback on the work that the federal government is now doing, and taking the benefit of that work and extending it to the rest of the residents of the state besides just the Medicare population. And then I think also a board could, depending again on sort of the level of dysfunction around certain therapeutic products or categories, use a UPL to support biosimilar adoption and undermine some of the manipulation we see going on in the market now, where the original innovator product is doing things with rebates and other machinations to shut out the biosimilars that are trying to get a leg up in the market. And in general, when we have more competition, it's sort of better for consumers. So using upper payment limits to spur competition and make the market operate like we think it should be operating. So next slide. So in terms of unintended consequences, Ralph, was I going to do this? Were you going to, I'm sorry, I'm sort of.
Yep, sorry, I think this is yours, Jane.
Okay, so we talked about the cost shifting already, basically. And then in terms of this other question that was raised about, isn't this just moving deck chairs around, or, is there really any change here? Like, for instance, if you were going to use the money that's already on the table in terms of rebates and structuring your UPL. So, health plans have all different levels of rebates depending on their ability to negotiate, the number of enrollees, the extent to which they're able to move product volume for a manufacturer. So in terms of if a health plan still has the tools in their toolbox to go after rebates or other price concessions, like the terms of their leverage don't change with respect to a UPL. So if they feel like they still want rebates, that the UPL isn't low enough for them or whatever, they can still use all the tools that they have had at their disposal to go back at negotiations with a manufacturer. That's sort of the main point here. Next slide. more about unintended consequences. So I've heard recently that the supply chain can't adapt to the UPL. And I mean, I think the supply chain probably can adapt. They may not exactly know what at this moment in time, what they are adapting to, but you know, there's lots of tools in the supply chain for getting product at the manufacturer agreed price concession to the particular purchaser. And that's chargebacks. There are lots of tools for the supply chain to be able to manage with upper payment limit products in a certain state, including, I mean, I think the state could even think about getting a dedicated wholesaler to handle the UPL products in specific, if the large wholesalers feel like they simply can't or won't do it. I've also heard that the UPL is going to affect Medicaid, and it is not going to affect the federal Medicaid rebates. That's statutory law, big national formulas that decide what the rebates are and all of these things that an upper payment limit in Oregon is not going to change. And, you know, Medicaid's leverage to obtain supplemental rebates is not going to change either, which is similar to the other point I just made about any health plan, you know, still has the leverage they had before a UPL. And that UPLs are going to drive more pharmacies out of business, and would be an unintended consequences. And I guess I think that perhaps the opposite may be more realistic about the effect of a UPL, in that we have independent pharmacies are really struggling around the country right now. They're typically, you know, their reimbursements are based on national average acquisition costs, and a lot of independent pharmacies can't get to that national average acquisition cost. They're paying more to stock the product, and they're getting reimbursed at national averages. And I guess I would say that with an upper payment limit, you know what the acquisition cost is. There's no reason to reach to national averages. And I think that pharmacies would have a much better opportunity of getting reimbursed for their costs than they have in the past.
Jane, I just want to jump in. Gil has his hand up.
Yeah, I think, thank you. I think you mentioned about 340B. I was just wondering if you might talk about that a little bit more, about how do 340B pharmacies, how are they impacted by the UPL?
So I've spent a lot of time thinking about that. And so 340B, the supply channel through the prime vendor or however an entity gets their supply, remains the same. And the 340B pricing doesn't change one bit. And the UPL is never going to be, as far as I can ascertain, anywhere near as low as the 340B purchase price is going to be. The board is going to be bound by, can't go any lower than Medicaid best price in the market. And the 340B entities get the best price, right? If there is a best price, they get the best price, plus they get the benefit of all of what I call those CPI penalty rebates. When a drug product price increases faster than the rate of inflation in a quarter, you have to pay more. And so, you know, those stack up over time. Well, a board is never going to be setting a UPL that reflects those CPI penalty rebates. And so the 340B entity, basically the 340B acquisition cost is always going to be much lower than the UPL. So, but you're going to have to bill at the UPL, right? So your margin on however many products a board chooses to do in a year, and it can't be too many because it's a pretty exhaustive process to get to that point. The margin is reduced, but I think it's still pretty hefty given there's so many products out there with the CPI penalty rebates now tagged to them. Does that make sense, Gil?
Yeah, thank you for articulating that. Thanks.
So next.
So I'm gonna, just before we head to the next slide, Jane, I'm gonna just call an audible here on the agenda. So we're gonna move the 10:15 conversation around bulk purchasing state multi-state agreements to an educational webinar. So we have a little bit more time on this. So people shouldn't feel pressured. We should ask the questions we need to ask, and then we can have a discussion later. Thanks. Keep it rolling, Jane. Sorry.
No, that's okay. Fine.
And Jane, oh, Stephen, did you have a question of Jane before I take the next slide? Go ahead.
Yeah, just wondering about the margin. I think it was on the last slide. So, you know, my understanding is that, or simplified understanding is, this pharmacies purchase the drugs and sell them, and the difference between the two prices constitutes the revenues minus the cost is the profit. So my question is that some sort of like higher price we sell it, is that margin, is that a percent of the prices, or is that an absolute price difference? If it's a former, then you would have some effects on the margin of a pharmacy. Is that correct?
So there's two components to pharmacy reimbursement, right? There's the product reimbursement, right? And then there's the professional fees for the services. So, and the product reimbursement, for as long as I've been in this space, has always been trying to approximate as closely as possible exactly what that pharmacist paid for the product to squeeze, make sure that there's not a lot of margin going on there. And then there's the dispensing fee. So it doesn't really change the dynamic of it.
So what you're saying is it's most of that margin is independent of the prices.
Most of the revenue of a pharmacy is independent of those prices.
Sorry. Yeah, most of our revenue is independent of the prices. So if you change the price, you don't change the revenue. Okay, good. Yeah, thanks.
In general.
So we have Melissa has her hand up.
I personally am just having trouble kind of thinking about contract pharmacy and pharmacy retail versus kind of how we think about this for outpatient or ambulatory pharmacy expense, when it comes to infusion or, services that have to be provided. So, I guess it's just a comment that it's kind of not one size fits all as far as where pharmaceutical expense comes into the cost for medical expense in the state, and how any of this work is thoughtful around the different avenues that pharmaceutical expense is driving up costs. And I just am sensitive because there are some drugs that have to be provided by a physician in an office or, in a hospital, either inpatient or outpatient, that we're thoughtful in this around those differences. And that there isn't a place where a physician or someone providing healthcare isn't taking on the burden of what insurers are paying and what that charges. And some of it may also go back to that discussion we had yesterday on allowable and the cost sharing piece for patients. So I'm personally, my brain's struggling a little bit on kind of the avenues for where pharmaceutical expense shows up. And I know a lot of people's frame of reference is related to retail pharmacy, and but there's also a lot of expense being driven in, what's being provided in a physician's office or ambulatory, or infusion.
Yeah, no, that's great points. And the states that have laws around this now, the board is to consider as part of the UPL, the administrative cost, the exceptional cost of a product in setting a UPL. So that's baked into most of the state laws at this point. To get to your point that it's not a one size fits all.
So can I feel like on this, there's sort of the policy around the UPL question. I have I think a more basic question is, I assume that each system, so Kaiser, Salem, Providence, that you all have a UPL for the ambulatory drugs, like for your own system. Is that true? Not true? Melissa?
I think everyone probably is procuring drugs at a different cost, right? And that is, you know, that, so there's that piece. Everyone's procuring drug at a different cost, and some of it has to do with your size and ability to leverage. You know, it has to do with how many, you know, aligned agreements you have with these PBMs or these manufacturers, you know, kind of bulk buy, you know, I guess that's what I mean. Like when you're bulk buying, you may be able to procure at a lower price than a smaller, and the charge model, I think it's, is a lot of the times what she's saying here, whether it's off whack or wholesale, and then there's some sort of model related to that. But that what is charged, as we all know, has very little to do with what is paid. Right. Often, unless it's some percentage charge and off contract, but for the most part, the charge model and kind of what you're speaking to, Felicia, has very little to do, and it really has to do with what the agreement is with the payer, and where there's often a disconnect, shouldn't be, but there can be, I guess, is what it's cost to procure and what a payer is willing to pay. So.
Thank you. I appreciate that. I don't know if there's any others that want to jump in on that. The other systems on the call, like I don't know, Salem, you're a much smaller. Okay.
Just maybe one other thing, and it speaks to the discussion earlier, and I shouldn't speak for another health system, but some health systems may set up agreements with payers to share in drug savings rebates, and others may not. I'm not familiar with that within our organization, but you know, it may be that again, I shouldn't be speaking like this. A facility of a health system like Kaiser, that drug rebate savings that we're talking about, you know, is part of the integrated model. But a lot of times health systems don't have that opportunity. It's on the payers.
Lisa, I think that, to Melissa's point, everyone negotiates the best possible rates. They have targets for what to pay for these drugs, but there's no external ability to say, we won't pay more than X for a drug that's necessary for our members or our patients. And so I think that's the difference that I see in a UPL, which is an external state-based. Hey, we've determined this is the top of the fair price that we can run through the healthcare costs in our state. And I don't think we as individual organizations, and I would open that up to any of you that wanted to comment, have that ability unilaterally to say, here's the max.
I appreciate that. I think that, I guess this goes to my sort of, I know we're in the unintended consequences, I feel like, but I want to kind of go back onto the UPL, which might be covered in the state-based, is if we're doing I understand the UPL that matches Medicare on the negotiated Medicare prices. And then are there other UPLs, because the UPL is then public, could you align your UPL with other states' UPLs? And do we have like a map of UPLs somewhere?
Not yet.
So Felicia, this is Ralph. If I can, not yet. Colorado is closest down that road, but I guess to speak to a couple things I've heard throughout this, and one that you had opened up with, in kind of me paraphrasing, but you know, states are social policy labs, absent federal government intervention, if you will. And to that point, we all are social policy labs, but also noting something that Melissa said, and that is that everyone procures drugs at a different cost. And candidly, this is a philosophical question. Is that right? Is that right in the context of health equity? Is that right in the context that if someone lives in Portland versus Brookings or Burns, that if, God forbid, they have cancer and need chemotherapy treatment inpatient somewhere, that the cost of that ultimate treatment is going to be dependent on the economies of scale, i.e. a rebate system, and I will speak to that momentarily too, that someone is paying more for that same drug because of where they live in a rural part or a metropolitan part of our state, or whether they belong to a smaller plan or a larger plan. And to that point, this is all, you know, and Jane put up, I think on the previous slide, several different models or options. One was contextually around rebates. And for folks that have known me long enough, they know that I like to get on my soapbox about rebates. And that is that rebates really just perpetuate a broken and distorted marketplace that can have unfavorable impacts on consumers. And candidly, one of them, and this was intimated, that some of those consequences can ultimately be the sick subsidizing the cost of the healthy. So if we're going to have this conversation, we have to have it in its totality.
So next slide.
And this is back to me, and thanks, Jane, and just so grateful for Jane's insight and ability to join us this morning. I think y'all are getting a great context for the value that she brings and the contributions to our work. So I was asked to speak briefly about the context and opportunities for future collaboration. Know that ourselves, Washington, Colorado, Maryland, and New Hampshire communicate freely and share our best practices amongst each other, recognizing that all of our state programs are different. As discussed, collectively, most all of the PDAB states get technical assistance from the Portal program at Harvard. That acronym stands for the Program on Regulation, Therapeutics, and the Law at the Harvard Medical School and Brigham and Women's Hospital, and that is all supported largely by the National Academy of State Health Policy, for which we are all collectively grateful for that support. And then very recently, literally in the past 2 or 3 weeks or so, there has been some very preliminary conversations with the folks at the Center for Evidence-Based Policy at OHSU about what a framework might look like for them to support a collective of PDAB states in doing evidence reviews and economic analysis. Some of that will evolve around context for pricing of the subject drug or cost, et cetera, and therapeutic alternatives, because that's got to be another part of this conversation too in any kind of upper payment limit setting. Jane intimated a couple of different potential models that could be based on a therapeutic class, but conceptually, again, you got to understand what is going on in terms of therapeutic alternatives. So I think that concludes our slides, and Felisa will look to you based on the audible that you called, and Jane and I are available to talk as much as you'd like to hear us or answer any questions that folks have.
Great. Yeah, here we go. Let's jump in with questions. So Eli and then Stephen.
But I'm piggybacking on Greg's question from earlier about how this could affect overall cost. And I'm wondering if there's any data out of other states that have already implemented something along these lines of showing the effect that it had on the overall cost of drugs. And if so, if there's any breakdown on the effect on different types of buyers, like pharmacies, hospitals, and patients.
Ralph, you want me to answer?
Go for it.
So the short answer is no. I mean, this is all pretty new. So as Ralph had mentioned, Colorado is just starting on their first upper payment limit, for instance. Minnesota, their PDAB is having their very first meeting later today, actually. And Washington State is in the process of developing regs, and they're not at the point yet of setting an upper payment limit for anything.
And then I guess, Eli, I would just add to that, to the point that Jane made, that all of these states that do have upper payment limit authority have a bit of a runway, I think, from 3 to 9 months or more for that rate that ultimately gets set to get operationalized throughout the different parts of the supply chain. And no one is there yet, so.
All right, Stefan?
Yeah, I wanna expand on that a little bit. So I think like again, like bringing it back to our overarching topic around cost growth. So it seems like to me the way I could conceptualize this is there's some sort of monopoly power in the prescription drugs, with some sort of prices are higher than they're desirable for consumers. There's some variation here that's based on market power that we discussed. That's probably not desirable, and so the UPL is some sort of a mechanism, a unilateral negotiation mechanism, so to speak, to reduce prices, so the upper limit, which is consumer improving. And if you have this kind of market power, because you essentially shift some of these kind of producer surpluses on the consumer side. So I think like that's the idea here. I think there's two things on this. The first one is like, so it's like, since this is very new, there's no evidence on this. My thinking is like, is there a way to kind of at least provide some way to estimate that, and I think that should be fairly straightforward, because right, so it's like when you think about like what's the actual effect of this on pricing, it's like that, how much are these UPLs actually, what's the difference between UPLs and the actual prices, right? So how do we measure, like how many drugs are going to be affected? And then how much is the drug price is part of the overall cost? And I think if you multiply with 3, you get some sort of an estimate of like what that would actually mean in terms of overall cost. And I'm not sure this matters really much, right? So I mean, like, I think one risk I see here is we're going to have a long debate. There's going to be a lot of discussion around like, it's like, how do we set them, and like all this kind of nuances and everything. But when it comes down to it, like once you sit down and like calculate that through, from an overall healthcare cost perspective, right, it might just not come out as a big cost saving. And I guess it's one thing. And another thing I want to say is with that one thing what I haven't seen here is you talk a lot about unintended consequences, but one of the intended consequences, I think, of this is, or one of the straightforward consequences is a demand response. And that means like, you lower prices, and that's one of the consumer benefits is, right, that you don't have a restriction on the demand for the prices, or that restriction is eased. You get an improvement in demand, which is good, which is great, which is what we want, right? If we think that prices are too high, right, and so demand is too low for some of these drugs. But it's, I think, something to factor in when you think about like what are some of the consequences for that for overall healthcare costs.
And I feel like I want to jump in here a little bit after that, because I think that I feel like this is a little bit of a, to your point about sort of the bang for the buck, as I kind of think a little bit about what you articulated, is the level of effort that we're putting in to have these sort of these very small cuts at what we could see as reducing prices. I think when I go back to Jane's first slide, unless we are willing to completely change the entire pharmaceutical market and industry in our country, we are never going to have a big swing. And I feel like the level of effort to do that, I mean, I'm down. I think we know that I am down for that. And it's been my career trying to take those big swings unsuccessfully. But I feel like, I think that the reality is we are in a little bit of a boat of taking these small sort of nicks and cuts at a very broken market, frankly, because the market is just fundamentally broken around, how drugs are manufactured, how we pay for research, the sort of prices that the pharmaceutical industry is able to set, that we have a for-profit pharmaceutical industry in our state. And then there's all of the issues around, patents that people love to talk about, and the issues around what is patentable, what is not patentable, what that looks like, how long those are, et cetera. and we're not willing to break those, like, I shouldn't say we, I am willing to break that market and rechange it. Our federal government is not willing to break that market, and states are attempting to take chunks at that market and are getting sued left and right. I think it's worth it for us to take the lawsuits to try to take those chunks and then to try to figure out how we do it collectively, knowing that it's going to take a lot of time and energy and it won't be these big swings. But I do feel like when you have a fundamentally broken market, we have to sort of take those chunks to send a message to that market. And it seems like, I think maybe I'm wrong, Jane, but I feel like one of the things you said is that the market has adjusted to regulatory interventions in a way that they might not like, but they've just sort of accepted some of them and made sort of substantial changes.
Yeah, I'm talking about the supply chain in specific, right?
Gotcha.
You know, that's
not the manufacturers.
And operational. Well, the manufacturers always adjust. It's not always what you would like. I'm just actually
badly. They just adjust badly.
Are adjusting to a couple things going on in the market now. Yeah, they always figure out how to adjust. But I would just say a couple things. Number one, now the insulin makers did it of their own accord, I think actually because of changes in the Medicaid rebate, but you know, knocking 70 or 80% off of the price of insulin when it was high enough that literally people were dying because they couldn't afford it. You know, that's not working around the margin for like those patients. And there's, you know, there's cancer products that are just considered financially toxic. You know, people don't show up for their cancer treatments because they can't afford it. So, I mean, I think that there are some really meaningful things to do here for consumers in terms of the grand scheme of things. The other thing I would say, and Ralph had said it far more eloquently, but you know, the feds take notice when the states really start to do things. And there are pieces of the Medicare negotiation that actually have pieces that law that actually have components of these sort of PDEBs and the upper payment limit kind of approach to things. So it does create change. And, you know, you get to a critical mass of states, like the whole Obamacare, that started out in the states, and Medicare DRGs was a state initiative in New Jersey, and the Children's Health Insurance Program was in a couple states, and then the feds picked it up. So, you know, the feds go where states lead. And if for nothing else than for that purpose also to engage in this would be important for the long game.
So I'm gonna go Stefan and then Gil.
I think Gil was first, so I would give it to him first.
Okay, Gil, then Stefan.
Okay, either way, I think if these upper payment limits have the potential for slowing the rate of inflation that we've seen in drug costs, you know, over the years, it's worth, you know, a try, you know, as a tool. You know, a lot of different things, because we, you know, we've just seen, you know, drug costs become a larger and larger portion of the overall total cost of care. I remember when it was more like 10%, 12%. Now it's 30% or higher. You know, when we look at, you know, $1 of total healthcare cost spending, but you know, so I'm all for trying, you know, seeing where this can take us. You know, with the example, I was just thinking about the insulin example, and so I think it's great that we try to make it more affordable at the patient care point of, you know, getting the drug. You mentioned that was essentially just recognizing a rebate cost that, you know, was already sort of in place. But so then is there a sort of a shift, you know, that happens then to the payer or to the you know, in that scenario, or is or is it just ultimately, you know, the net result is you know, the manufacturer's just making less on that than what they otherwise would have, and the consumer is benefiting. I'm just trying to follow the numbers there.
It's really hard. So it depends, like, sort of how it's done. So if they're already giving back 70% of what they, you know, what they got paid for the drug when it left the wholesaler, if they're handing that out, you know, their net on the product was 30%. So I think it stays the same for them, right? And potentially their sales go up because people are actually buying the insulin now. So that's one way of looking at it. And then there's another way of looking at it, which is something else that they have done. And I do think that that is this next thing, which is just limiting the cost of a month's worth of insulin to $35. So all of the companies, the 3 companies, are doing that also. And I believe, you know, that's a cost shift to the payers at some level. And the intersection, I can't actually speak very intelligently about the intersection between the drop in the WAC and the $35 insulin. But I do know, like, Lilly set up like their own supply chain basically, and have contracted, or they have someone who has contracted with pharmacies who agree to dispense for $35 and no more. So they're trying to get around the PBMs basically at that point. Anyway, it's very complicated, but in some cases it's a cost shift to the insurers depending on the product and the manufacturer and what they're trying to do, and other times it's just a price cut.
So we have just a couple more minutes. So I want to make sure if there's anybody who wants to sign up for public comment, that there's an opportunity to do that. I'm going to ask board members if we can stay about 3 minutes over so we can finish this discussion. And then I'm going to go Stefan and then Teresa.
Yeah, thank you. Yeah, I just want to first clarify, like, I think this is a good idea, Jane, and thank you for presenting this, right? I'm not opposed to this. I just want to some sort of, like caution us or everyone here to, sometimes it's easy to get wrapped up into details and have a big picture in mind. And then the other thing is I just want to make it clear from some sort of way of assessing that upfront, like through a simulation or just like back of a hand calculations. This can be easier, it can be more sophisticated. There's policy think tanks that do these kind of simulations to study how this can actually matter, like Mathematic or RTI or an institute or whatever. But it doesn't have to be perhaps at that level. But it's like right now, I don't see anything that helps me understand how much that can make a difference. And I think it would be nice to have that somewhere.
Stephen, thank you for that. And if I can, real quick, a couple things in that. One of the things I hope is a big takeaway for you all today is, hello, this is complicated. We weren't coming to you to say uniformly support upper payment limits. It's really a simple construct, as you've heard from your own members of questions of how would drugs be treated across the supply chain, from physician administered to infused products to those distributed at a community retail pharmacy. We've heard about issues of metro versus rural. We've heard about things like bulk buying, if you will. So there is no singular solution for this. And I just say that out loud because I think, as Felicia even opened up, is, some of the work of this committee is to help with big, bold policy ideas and leave it to other folks to figure out the in the weeds operational aspects, if I can safely paraphrase that, Felicia. But to that point, that is what we are trying to do. But again, part of this is bringing to you just to have full awareness on your part, as not just the complexity of operationalizing it, but the respective businesses for which all of you are here, and employed by and represent in many ways today if you're not here representing yourselves personally. So some of this was just to deliver the message that this is complicated. There is no one-size-fits-all approach. And so more to discuss, certainly. Teresa?
Yeah, thanks.
Yeah, thank you. Really appreciated the conversation and learned a lot. And sounds like, you know, there's some real possibility here with these upper payment limits. Like the rest of you, I'm trying to figure out really where the costs, you know, it's the balloon, and if you remove it out of one area, where is it going to show up? One thing I've just been wondering about is, I know that in Oregon, the thought is that we would apply these for government payers, or at least maybe that's the current thinking. And so just wondering if that means that the commercial payers, I guess, then are still subject, would not have upper payment limits. Is that a potential question?
To level set that, and not as a cost shift question, but the directive under Senate Bill 192 of last year, of calendar 2023, the short session was for the board and our staff to come back with an operational plan that makes sense for all payers, both government and commercial. So thus the ask for us that I mentioned earlier, that we'll be engaging with carriers, hospitals, pharmacies, and other folks. So I think one of the seed questions that we had talked about with Sarah earlier was, what can this committee do? And candidly, amongst yourselves, the ask of you is to help us in engaging the folks that you are, your peers, your cohorts in your respective organizations or associations, that when we communicate with them on this, get on board. We are not asking for unconditional support for upper payment limits. We are asking to take your respective organizations' temperatures on where you're at with this. Again, identifying what you like about it in terms of strengths and opportunities, and what some of the stumbling blocks are that might find as less palatable in terms of weaknesses or threats. And from there, let us come back together as a board with our contractor and try to present something meaningful to the legislature.
Okay.
So I have a couple of things. So I have Greg, and then I have Tom signed up for public testimony. So Greg, if you can be quick, and then if people really can stay on for the 3 minutes, we can hear from Tom. I think that's really important. So Greg.
Oh yeah, so I just dropped a question in the chat, and maybe I'm confused about something, but I was wondering if payers are currently buying drugs for that are being delivered to Oregonians all within the state of Oregon currently, such that if a UPL was implemented in Oregon, it would be effective, it would be, you know, governing those purchases, rather than if payers are buying drugs from other states currently, a UPL in Oregon presumably wouldn't have an effect. How does that work?
And I think, Greg, to your specific question, that would likely need to be best answered by the individual payers.
Which I think was to Melissa's sort of earlier point, the discussion earlier, that when you have a big national group, you can buy them nationally. So I don't know. I feel like Pradesh was on, but maybe he had to jump. And so like, I know that Kaiser buys their drugs nationally, but my guess is Samaritan buys their drugs locally. So it really will depend on the size. And I think that that's something to consider in the sort of how the PDAB moves forward with the policy. I'm going to ask folks, if you have additional questions or thoughts on this, please sort of put them out. And I've heard a couple of requests, like Stefan, to sort of, how do we do the research to sort of get to what is the actual math and amount, and not get too over our skis into this is the silver bullet for drug costs. I've heard requests from Ralph to sort of float some ideas past our sort of our connection groups to see that if we can give feedback on how we get to sort of meaningful legislation on this. So asking people to do this. And then we're going to have a webinar on purchasing that Sarah and the OHA team is going to put together, I assume probably with Ralph. Not with Ralph, somebody else. Fantastic. Sorry, Ralph. But with the purchasing, and so bringing those questions to that. I want to give Tom Sinek, who's signed up for public testimony, some time. So Tom, if you can jump in here, limit your comments to a couple of minutes, that would be great, knowing that we will have additional questions, and PDAB is also a public meeting. Tom,
well,
you.
I'm here. Thank you very much. I'm Tom Sinek, retired nurse practitioner with Healthcare for All Oregon. I love the opportunity to listen to this conversation. It's very dynamic, and therefore I have my opportunity to list my comments. One is very excited about the June 4th OHPB public comment period. Very exciting to know about that. And clearly, yes, we have a broken market and a broken healthcare system. One thing is an example by people deciding to stay in poverty so they can cover their cost of their medications. And, you know, how more broken can we be than that? You know, than the idea I need to stay in poverty, because not me personally, this is the stories that people are coming to us with. So I can get my health care, I can get my medications, et cetera. One of the things to be noticed in this cost driver, of course, is that the penalties for some of these pharmaceuticals, or wherever you put them, I'm not sure they're going to be large enough, because the pockets in some cases are so deep that they don't care. Example, you know, big example is Bayer's fine for $1 billion or something like that, not just pocket change to Bayer Corporation. One of the cost drivers that's coming up is this mergers and acquisitions issue. We know that these mergers and acquisitions looks like they increase cost while driving down access. So very important that this mergers and acquisition stuff become more robust, including the issue that United Healthcare is now been exempt from, I'm not sure where they'll fit into this process as an organization, as they've taken over and attempt the Corvallis Clinic and try to take over other aspects of our healthcare. Their pockets are really, really deep. You know, there's no expectations that we know of on them since they were exempt from the law. So I guess I'm very excited to hear what the goals that Ralph laid out. Those are very great goals. And that's, I think, the comment of we need to transform the system is very, very important. And I think, let's see, I think just talking about the issue of putting the backs on providers, you know, one of their cost drivers is billing systems, including billing for pharmaceuticals, right? Billing for care. So this issue of the billing that they have to take care of is a cost driver. And the fact that they've got to bill all these systems and then they take the burden in terms of your cost containment measures, I think is problematic. So I think that's what I have to say in terms of my comments. Thank you very much.
Thank you, Tom. So I think that there's a lot of different components that came up in this conversation and as we wrap up. So we're going to do an April educational webinar on other states. If you have sort of committee members have specific interests or questions about other states or policy work, please send those to the staff or to help develop this educational webinar. I think the next cost growth target committee meeting is going to be April 23rd, 9 to 10:30. We're going to talk about cost drivers at the state and federal legislation and a cost equity framework. I think that there's been a couple of items here raised around equity. There was this sort of rural, urban, this sort of poverty on drugs piece. And so I think if we can think about those two as we head into this, as we set up the educational webinar on state purchasing, as well as we bring in other questions about this upper payment limit concept. I also want to direct people to the website where the list of topics are coming up. So people can see which topics are going to be at which meeting and encourage members of the public or other folks, if we could push those out to people that you think might be interested so that we can get participation in our future meetings, that would be great.
May I just say one quick thing? Can we get rid of the word consumer out of this language? That is part of the problem with the system, how we reference people in need of life-saving care. So thank you very much. All right, buddy.
All right. We have a thumbs up. We're going to take the word consumer out of this. So yeah. And then Sarah put the schedule in the chat. Anything else for the meeting? Perfect. Thank you all. See you next time.
Everyone.